And by the way, I like your shirt.
Thank you. I made it myself
Did you
a
really?
while ago. Yep.
Oh,
Yeah.
that's really
I like
nice.
that's like one of my hobbies. I like to craft things. So
Oh,
got
sweet.
into it and now I can't stop.
Do you do you sell them?
No, no, I don't
Oh,
sell it. I just occasionally if someone I know is like, "Hey, can you make this for me? How much would you charge?" then I'll sell it to them, but I don't like run a storefront or anything cuz it's just too much work.
it really is. You're already
It's
dealing
so
with a
much
lot,
work. It seems like it, and you
right?
wouldn't think it is.
Ladies and gentlemen, welcome back to the Everyday Hero Show, where I bring to you someone in your life or someone in my life that brings good things, that does good things for the people around them, but does not get the credit that they deserve. This week we have Piper. Miss Piper, thank you so much for joining us.
Of course.
Piper, so you're a NICU nurse, right?
Yes,
Yes.
yes. I work
As your
in
shirt says.
yes, exactly. I work in a level 2 NICU, which is more stable babies, but we do stabilize more critical babies before we send them to a higher level hospital. And we see all kinds of things. I've seen, things as young as 25 weeks, some younger, and but we take everything pretty much.
So we are going to get into the depths of NICU nursing, but as much as I can get into. But before we get into, I want to know who Piper the human being is. So I start this with everybody. Who are you? Where are you from? And why nursing?
Well, my mom is an immigrant from actually Ireland and Australia, and she raised me pretty much by herself from the time I was like 6, I believe, in Oregon. And once we were there for a while, she decided that she really wanted to move somewhere sunnier because it rained like every single day and it was just really, really rainy all the time. So when I was about 16, she moved us here to Georgia, and I have been here ever since. And she just actually moved to Florida. So now she lives by Disney World, and I stayed here because I met my husband when I was 17. And so we just started dating. It became rather serious. So I stayed in Savannah, Georgia, and it's really quite beautiful here, and I'm starting to do a lot of the tourist things around here to get like to know more about my city and everything. So it's really cool. I was supposed to go to the St. Patrick's Day parade this year, which is a huge thing here in Savannah, and it didn't work out because my husband just had surgery
I'm sorry to
this
hear that.
week. So it didn't work out, but it's okay. Everything's all good. He's healthy and everything. So we're just recovering from that. But basically, I wanted to be a nurse from the time I started high school because I really just felt like I wanted to help people and I wanted a good, also, my mom, she works in IT. So she knew like the threat kind of like outsourcing jobs and that it's better to have a hands-on type of job because it's less likely to be outsourced. And that was a big thing. And her company was outsourcing. So she always kind of encouraged me to get something that was more like you had to do it in person in order to know that I would always be stable and always have a job. And so nursing just kind of fell right into that. And then it was also, I was, looking at budgets of stuff and I didn't want to go to college for a really long time and be in a lot of debt. And so I was like, nursing just seems like it's good. And if I don't like it, I can always be a professor or something else because nursing is so wide and so variable. You can do pretty much anything. That's really what drew me to it. Is I was like, even if I don't like it, I could be a professor or I could be like a school nurse, which is almost like a teacher, something along those lines, or do something else entirely. So that's kind of what drew me to it originally was just the variety of everything and how flexible nursing can be. I
It
really
really
like that.
is. I always say this, like nursing is one of the like very few jobs or professions that you really can take so many different places. I mean, like you can
Yes.
do so many things with the nursing degree. Just a quick clarification question. You said Irish and Australian. Is she Irish and then lived in Australia, or is she both half and half? Like, what did you mean when you say that's her ethnicity?
So she's actually Irish, full-blooded. But her
Okay.
parents did move them to Australia when she was about 10 years old, I believe. And so she kind of grew up there until she was
Okay.
about 18. And then her parents moved back to Ireland. And then she moved to, I believe, Japan for a few years and taught English. And then she moved to the United States. And her brother lived in Australia for a long time. He did their military, I think, in Australia, and then he moved to Canada. And so they're kind of all over the place, but she has a mix of accents. Her brother has a very Australian accent. She has a very kind of mixed accent. She kind of sounds like she's from Boston a little bit. A lot of people think she's from Boston because she says like banana and get in the car. but almost everything else is pretty normal. So that's why I just say Irish and Australian, because if
I
she
like
talks to
that.
her brother, she sounds Australian. If she talks to her parents, she sounds Irish. It's
That's lovely.
all together, but she is full-blooded just Irish. Yeah.
Have you been to Ireland and or Australia?
I went to Australia when I was a year old, so I don't
Oh,
remember that
okay.
at all. But I did go to Ireland when I was about 11 or 12, I think, for a summer and stayed there with my grandparents. And that was the last time I've been there. So it's been a while, but it was really fun. I got to stay the whole summer, learned about their shopping carts and something called a
Shopping
boot
carts.
sale. Yeah, their
Wait,
shopping
wait,
carts.
wait. Teach me about the shopping cart. What is it special about the Irish shopping carts?
They're like, which I hear it's kind of like Aldi, if you've ever been to an Aldi, I guess.
Yeah.
You have to put like a pound coin in the
Oh, I
cart to unlock
see.
it, and
Yes,
then you take it in
yes.
the store and you have to return it in order to get your pound back. And that was never something that I saw like here in the US until that time. So I was like, this is really strange. Like they really are serious about their carts
About the
here.
shop.
They think
Oh
people are going to
yeah.
take them.
No, but
And
the thing is, if you pay for a shopping cart, the likelihood of you like taking it, like the kind of person that will pay for the shopping cart is the kind of person that needs it to go shopping, and then they are
yeah.
much more likely to return it and not. You know how you go to some like shopping centers and you see like a Walmart cart like 3 miles away from the Walmart. Yeah,
Oh, yes.
yeah.
Yeah, all the
So
time.
and you never see that at Aldi's because you have to pay for it. Lovely. So
Yeah, yeah,
that's
that's what
how
I hear. I haven't been there.
I always like getting a good history. But when it comes to the nursing, I understand that it for me it sounded like the way you described getting into nursing, it sounded like it was the most logical decision for you. I know you said that you wanted to be a nurse since you were a freshman in high school or since you were in high school. Is there a why? Is someone in your family a nurse, or was this something like this is something I think I might be able to do? Because I know when you're in high school, it's literally every adult you meet is like, what do you want to do when you get older? So like, I
Yeah.
feel like sometimes when you pick an answer, it kind of sticks with you. But is there why? Did you have any influence, or is this just something you felt?
I actually don't have anyone in my family that's a nurse. No one prior to me that I know of went to college. Like my mom didn't finish college. My dad, I don't think went to college. I don't think that my grandparents did either. I'm not 100% sure on that. But nobody in my family is a nurse. Nobody's in healthcare or anything. My mom worked for a health insurance company. And so she got to talk to a lot of nurses and doctors and that kind of thing. So I was kind of exposed to it from the get go, but it was a very logical decision. And then as I was like discovering more and going to college, I realized that I really wanted to do something that I felt mattered and something that I wasn't thinking, I'm going home and I'm not making a difference. I wanted to do something that I could really help people that needed help. And I felt like I really like to not only talk to people, but I just feel like I really like to be compassionate, and I always am putting myself in other people's shoes. So I felt like that was really what drew me to it, because even like standing in line at the grocery store, people are like, "Oh my gosh, this is taking forever." And I'll be like, "Well, I mean, what else do we have to do? Nothing. It's okay. We can just wait. It's fine. The
Deep
cashier
breaths.
might be having a really bad day
Yeah.
or whatever." And people would get so frustrated, things like that. Like I would always put myself in other people's shoes. If someone was like super rude to me or something, I'd be like, well, my mom always taught me, you never know what's going on in their day. Maybe they just found out that someone in their family has cancer and they're very upset and they're taking it out on you. Like, it's not a big deal. Don't worry about it. And so I feel like that kind of mindset just made me want to help other people and see how they kind of, how I could put myself in other people's shoes, I should say. That's kind of what drew me to it, I think. And just
I love that.
everything. I love
Yeah.
everything about nursing.
Yeah. So I don't know if I can agree with you on that, but so now that we know why the nursing, I'd like to know how you became a NICU nurse specifically. When you got into nursing, once you started nursing school, was it during your peds L&D rotation where you're like, oh, this is definitely for me? Did you spend any time with adults, med surge at all, or have you always been NICU from the get of your nursing career?
When I started nursing school, I did not know what I wanted to do. I kind of assumed that I would just go into med surge like every professor pretty much tells you to do.
100%.
And yes, and I was like, okay, I'm good with that. I worked in a pharmacy at the time as a pharmacy technician because I thought that that might help me with nursing school. And it taught me so much about health conditions and different medications and what they're for and how to deal with angry people and how to deal with upset people and time management, all of that. It was excellent. Like that would be my number one advice to anybody who's in nursing school is to be a pharmacy tech because it was super helpful. So helpful. But I decided that I just wanted to be a nurse, but I didn't know what kind. So I was like, well, I'll just play it by ear, figure it out, go with the flow. So I went into nursing school and just had an open mindset. And then I don't think I did anything pediatric or NICU until my senior year, I believe. I could be wrong on that. It gets fuzzy after a few years,
Yep.
but I can't remember which semester, but I know that I did do a pediatric rotation. And in that, they gave us one shift of going to the NICU. And I went to the NICU and I was like, this is kind of cool. Like, this is really interesting. I've never seen this kind of thing before. And I just thought it was very interesting. It's just so different from other parts of nursing, but it's also very similar, in my opinion, to like older people. And I always thought that I would work with like the elderly because I just thought that that was so fun. I really loved elderly people. And I was kind of deciding between working with NICU and working with the elderly. And I decided that kids were definitely not for me. Pediatrics was not for me after a clinical rotation where, like, a lot of times in peds, I've found that the nurses have to be the parent and they have to kind of parent the child for the parent because they won't listen to the parent. And I was like, that's not for me. I can't do that. I cannot do it. So I was just like, babies, they can't really talk back. They can't really fight you. It is what it is. When you have to do something, you have to do it. And I was like, that, that's kind of nice. And I worked as a tech at the time, a PCT, they call it here, patient care tech. I worked as that at one of the hospitals as well as being a pharmacy technician and had several just not good experiences with adults. And I was like, well, I'll still consider doing med surge. And I actually interviewed to do NICU and med surge. And I got offered jobs in both. But I know that NICU is very competitive. And I was like, okay, well, I'll try NICU. Since I got offered the job, I'll try it. And if I don't like it, I can always go to med surge. It's not usually the other way around. It's harder to
Yep.
go from med surge to NICU. So I was like, I'll just start NICU. And if I don't like it, then I'll go to med surge. Not a big deal. But I ended up loving it. So I just stayed and I've been doing that for like 5 years now. So I've been doing it for a while, but it was just, I don't know why, but the little babies always fascinated me. And then during my clinical rotation, some of the other people in my clinical group did not want to be anywhere near that kind of stuff. They did not care to see it at all. And so they offered me their day to go to the NICU instead. So I ended up going for like 3 days instead of one day.
Oh, that's
And then I
lovely.
shadowed there too. So it was just like I got to see it to really decide if that's what I wanted to do. And tried it out and loved it. So I've been there ever since, but I haven't been a nurse to like med surg patients as a licensed registered nurse. I haven't actually done med surg or anything like that.
So you've been a nurse for 5 years. You've been a NICU nurse for 5 years.
Yes.
Okay, so
Yep.
this is your bread and butter.
Yes,
Oh, good,
exactly. Yes.
good, good, good. Because I've
I've
got a
been at the
lot of
same place.
because when you, especially when you said like, being a NICU nurse is like very different than other types of nursing. It really is. Like I always felt like there's, if you work on a med surg floor, if you work on a tele floor or GI floor, oncology floor, yeah, there's different aspects of the nursing. But when you go to places like labor and delivery, when you go to places like the OR, when you go to places like the NICU, these actually feel like entirely different jobs. You might be called the same thing, a nurse, but it
Yeah.
feels like an entirely different job. And that's why I think, I don't know. I just want to understand it, because it is very different. And what you said
Yeah.
at the end is spot on. You meet nurses, you meet people who are like, I absolutely want to or love being with babies, or absolutely not. I can't ever do
Yes.
it. Right? There's very few people where it's like, I don't know, maybe. No, it's like you either in or you're either out. Right?
That's exactly what we see all the time whenever we have like nursing students or people that come up. They can almost tell immediately whether they are going to want to do babies or absolutely not, never want to touch a baby
Yeah.
again. And it's one or the other. There is never an in between. And I will have people tell me, they'll be like, I could never do what you do, but I'm also a nurse and I work at this other hospital. Like it's all the time. And I'm like,
Yes.
yeah, it takes a very special type of person.
So let's get into NICU nursing, please. Because I really, it's really hard, right? I want to ask you like, how would you describe being a NICU nurse? But I feel like that's just too much. So I'm just going to break down like what I see or what I think, and then you please correct me and excuse the ignorance, please and thank you.
Oh
Um,
yeah.
first of all, what is considered premature? Like technically, what
Um,
is considered a premature baby?
Technically there's different stages of it. So there is like late premature, which I believe is anything from about 36 to 38 weeks is considered
Okay.
late prematurity. And then under 36 weeks is considered premature. And then there's like severely premature, which I think is under 28 weeks, but I could be wrong on that. But there's like different stages of it. But basically, anything under
38
38
weeks.
weeks
Okay.
could be
So
considered a premature baby.
gotcha. Gotcha. Um, and I just wanted to get that cleared out because and like when you go to when you just I just had a baby. So like I'm just like in the heap
Oh,
of like understanding like babies. Obviously, I'm out of the hospital. Things have been great.
yeah.
But everything that I was told coming up to it was basically like 36 to 40 is technically considered like mature, but I was like, that's a big gap. That's a full month, right? It can't
Yes.
actually be that 36 to 40 is considered normal. So it helps to know. It helps to know.
Yeah,
Um
it's usually 36 weeks is considered like the age that we would be able to let them stay in the room with the parents if they're completely stable and everything.
I see.
So that's usually why they say like 36 and on is okay, because those are usually the ages that would go home with
um
you.
I'm so sorry. Can you just say that last part? I think I said something that sounded like anyways, what did you just say? You said 36 weeks. Is technically when you can let the parents stay in the room.
Where you can let the baby stay in the room with the parents.
Okay.
They wouldn't
Okay.
immediately have to be admitted to a NICU type area. If they're 36 weeks or above, they may just require some monitoring or some extra tests like blood sugars, that kind of thing, if they're 36 weeks. But they can technically still like go home and be perfectly fine.
If you had a 34-week-old baby that's super healthy, APGAR score out like through the roof, does does the baby still need to go to a NICU, or can the baby go to the parents' room?
It depends on the NICU. Different ones have different protocols for the ages that they will let stay in the room. At least where I work, our protocol is that under 36 weeks,
You
they
have to
have
be
to
monitored.
come and be
Okay,
observed at least for a short time period. And they have to get like extra tests done, like blood glucoses, that kind of thing, just to make sure that they're okay because they're at risk for more things than a generally full term baby. But usually, if we had a baby from a young gestation that was like 32 weeks or something, and they were super healthy and they were doing everything that they needed to do, and they aged up to be 34 and a half weeks or something like that, it is possible that they could go home at that age as long as they reflect that they're able to do everything that they're supposed to do. But sometimes they will have to hold them to be at least 35 weeks in order for them to go home.
let's talk about you onboarding, like when you first starting to be a NICU nurse. Okay, do they make you as a NICU nurse? Make you is it protocol when you are becoming a NICU nurse? Do you need to spend time in L&D? Do you have to spend time in the postpartum before they upgrade you to the NICU, can you just start straight in the NICU?
I did just start straight in the NICU, but we are cross trained to labor and delivery and mother baby, and I was also cross trained to pediatrics. We have a really small pediatric unit, so I was cross trained to that as well. But I was trained in labor and delivery to only do the babies, so I don't know anything
Okay.
about the mamas. I don't do any of that stuff. I just do the babies because they usually have one nurse for the mom and one nurse for the baby.
Yep.
So if it's a busy night where they think a lot of babies are going to be delivered and we have too many nurses, then one of us will go down there and we will do all of the babies that they have that night. And
Makes
then we
sense.
also get cross trained to mother baby, and it depends on your history and your previous skill set as to whether you'll take full couplets, which is a mom and a baby, or if you just take the babies. I did take moms and babies when I first started, but that got phased out, and now we just do the baby portion. So we get paired with another nurse who gets all the moms, and then we get all the babies for their matching rooms. And so we're like a little pair that walks in and out. But I didn't have to work on either of those floors prior to being on my floor. I just was cross trained in them. So I get some focus, some experience on their floors before I'd have to go down there.
So I'm a travel nurse, and I worked at the hospital once where they had me go down to do mother baby, but they never allowed me to do any baby stuff. I was exactly how you said, there was a pair of us, and I was responsible for doing the mothers, and then the other
Yeah.
nurse that actually worked down there was responsible for doing the babies. And it really is a different world, right? Like, I know that working in the NICU is a situation where things aren't going great, but labor and delivery, mother baby, those are like one of very few situations where nurses required, where it's like a good time, where people are
Yeah.
actually happy. And it's such a different, like, going into work, going into those working on that unit, it's such a different feeling, because my entire life, my entire time being a nurse, every time I walk into a room, it's someone's worst day, it's someone's sick day, it's someone that doesn't want to be bothered, someone is in pain. But in these
Yeah.
situations, yes, mom is not feeling great, she just gave birth, obviously, but they're like through the roof happy, right? They're through the roof happy, which is so different. It's so different. Explain to me the emotions, please, because the NICU is like, it's just so scary to think that like a helpless baby needs to go to an ICU. Explain to me the emotions that you see mom, dad, just the family is going through, specifically mom is going through when they are told, or even like the buildup where it's like your baby might be going through the NICU. Explain to me how you guys deal with it, and how the mother, not on average, but what you see most often.
They luckily we keep it pretty positive most of the time. There's still a lot of like, congratulations, your baby's doing this and this, you know. We try to keep it very lighthearted and everything. We most of the time, if a sorry, you might be able to hear my dogs, they're barking at something.
How many dogs you have?
I have three.
Of course, yeah. You have three dogs.
Yeah, they're upstairs running around right now.
Okay, goody.
But anyway, okay, so we try to keep it really lighthearted, and we try to keep it as positive as possible. We try to highlight the positives so that they aren't as stressed. But a lot of times when they do come to our hospital, if we are expecting that they're going to deliver at a premature gestation and they're there for a few hours or so, our doctors will go and see them prior to them delivering and tell them what's expected. And they'll tell them, you know, what we would expect for their gestation, how long we would expect to keep them, what complications are possible, how, you know, why they would need to be admitted to the NICU, and what we would potentially be doing to them, and all of that. So they do a consultation before they deliver most of the time. If they walk in off the street, usually the labor nurses will tell them while they're like rolling them into the OR or to the delivery room, they'll say, hey, you know, because you're 34 weeks, your baby is going to have to go up to the NICU, just so you know. And then whenever we get called to the delivery, I also attend the deliveries as a charge nurse. I will attend the high risk deliveries. And the doctor will usually, whenever they walk in the room, they'll also walk up to them and say, hey, I'm the baby doctor. I'm just letting you know your baby will have to come up to the NICU because it's under this gestation. And whenever you're able, usually the mom is, whenever she's able to get up and go to the bathroom, then she can come and see the baby. But we always bring a family member up with us most of the time whenever we bring the baby up to the unit. And then we tell them everything that we're doing to the baby and what the initial plan is. And then the next time they come together with the mom is when we kind of explain like how long we think the baby might be there, what we're planning to do, everything like that, and what she could be doing to help her baby, like if she needs to be pumping or if she's not interested in pumping, or anything else that she can be doing. But we do see a lot of anxiety, I think, is the biggest thing that we see. We don't see a lot of, there's never really a lot of full-on sadness. The moms particularly, there's almost never any real anger most of the time. We get that more from the other family members might be getting angry. The only time we might see more anger is the longer they stay. We usually call it NICU-itis. If they start getting agitated by every little thing or every little thing a nurse might say, then we're like, they have the NICU-itis. The baby needs to be going home soon. They have been here too long, because they're finding little tiny things to get angry about. And that's usually just them getting antsy about the baby coming home. But most of the time we just see a lot of anxiety. We've noticed, like, I was talking to one of the nurses, actually in mother baby, not even on my unit. And she said in the last 10 years, she thinks the amount of anxiety in patients has skyrocketed. She said she's never seen it so bad as it is right now. So I think that's most often what we see. Most of the time the mom is so kind of out of it that it doesn't really hit her until later. And then she might cry a little bit. But usually once she comes and sees the baby and we do explain everything to her and we try to let her hold the baby if she can, then she's all good. And she realizes that, like, we are there to help the baby. We're not trying to keep the baby from her. We just want the baby to be healthy enough to go back and be in her room with her, or stay and grow if it needs to, that kind of thing.
Many questions. First of all, Piper, charge nurse 5 years into the NICU. My goodness, that's some real shit, Piper. What are you being so modest for?
It's a very small unit. I think I've been a charge nurse for the last 3 years.
Oh, so they really toss you in there.
Yes.
They believe in you, Piper. You're good at what you do. So you said baby is born, you have to take baby to the NICU. You explain everything, but you have to take someone, right? You have to
We
take
don't
a family.
have to. but
But
we usually do encourage them to come so that they can see where the baby is and kind of take some pictures of the baby, maybe with its monitors on and everything. So it's not as scary for the mom the first time she comes up. I'll usually encourage them. I'll
gotcha.
say, take some pictures, show them to mom. So when she comes up, it's not as scary because I'm explaining to you what all these are. These are all stickers. This is another sticker. This is like the blood pressure cuff because it looks really scary with all the wires on there and everything. But if
Yeah.
I explain what everything is, then they kind of are like, oh, okay, yeah, that's fine. That's fine. And they get more chill about it.
And I think about that all the time because even if you like as a nurse, I look at these NICU babies and I'm like, oh my God, there's so many things, right? There's so many things, but at the same time, it's like they don't. I don't want to say they don't, but because sometimes they do, but compared to like an ICU patient, they probably have the same amount of tubes, lines, and all of these things. But because the baby's so small, it looks like it's just all over, right? So it's like
Yes.
it looks so much scarier when it's on a little tiny human being because a big
Yeah.
person is like, okay, that's obviously the telly, that's obviously the IV, that's obviously, if vent whatever. But on babies, it's like that baby looks like a machine because it's connected to everything. And
Yes.
it really does look scary, even for a nurse. I can't imagine like mom seeing baby for the first time. That would be really scary if you didn't prep her and let her know. That is
Yes,
so
exactly.
good. That's such a good idea. So you talk, and something that you said that is is surprising to me. You're saying that your coworker thinks the anxiety is the highest that it's ever been. Is Do you agree with it? Number one, and number two, is it more anxiety than you felt during COVID, or are you saying like generally in the last year or so, like carrying the COVID anxiety with these days? And if it's not the COVID, why do you think people are so much more anxious than they have been in the past?
I don't think that it's like increased since COVID. If anything, I think it may have decreased a little bit because the restrictions have relaxed. So it's not quite as terrifying. But I do think that overall, over the last 5 years, we have seen more anxious, more stress in our patient population. Even when I go to Mother Baby, like the amount of people that call to ask, the baby's making this weird sound. What is it? And I walk in the room and the baby's hiccuping. And I'm like, oh, it's a hiccup. And they're like, is that normal? And I'm like, yes, that's normal. It's okay. But I mean, you can get that call, especially on Mother Baby, 5, 6 times a night, get the same
Okay.
call from different people.
Yeah.
And so it's kind of like, it's just interesting because I think that the amount of anxiety has increased. And I don't know if that's particularly related to one thing. It could be partially related to like our accessibility to Google and social media and all those things. I mean, if you're about to have a baby and you're thinking it's premature, you're going to Google
A hundred
what all
percent.
these things happen
A
to
hundred
premature
percent.
babies. And then, they come in and we've had several parents that have been like, we'll tell them something and they're like, oh, okay, yeah, I Googled that. And we're like, okay. And I had a
Yeah.
patient not too long ago, the mom called herself the Google Queen or something like that. And I
Good
was
for
like,
her.
yeah, I was like, that will make you a little anxious. Yeah. If you Google every single thing that could go wrong with something, it will make you more anxious. And yeah, I feel that it really does. It has increased over the last however many years, the amount of anxious people that we have. And they're not always like diagnosed with anxiety, but you can tell by the type of questions they ask and the amount of stress that they have, you can tell that they're anxious. And sometimes it's over things that don't really matter at the moment. It's just like they're finding something to focus on. And that's where a lot of the agitation, I think, comes too, is just from being overly anxious and not knowing what to do about it. And the fact that they have no control, a loss of control is really, really difficult.
Yeah.
And I totally get it because that's their baby. They've been told from day one that they can do what they want with their baby. And then when someone comes in and takes their baby and does what they want with their baby, then it's kind of very terrifying to them. And I get it. But yeah, we have a lot of a lot of problems with a lack of control. That I think that's mostly what makes people anxious is just the lack of control.
Just a few really quick questions here. What is the average nurse to patient ratio in the NICU?
It
You
depends on
don't
the
have to
NICU that
speak.
you go to.
You don't have to speak specifically to yours, but like, is it on average like ICUs 1 to 2, or is it different for babies?
From the several NICUs that I know, there's also different levels of them. So depending on the level that you're in can
Oh, I
determine
see.
how
Yeah.
many babies you can get. And
And you
also,
said you're level 2, right?
yeah, we're a level 2. Usually the ratio is 1 up to 4. Sometimes it's 2 to 4, usually is the range that we go to. But there's other places where their like unit that's like my unit, kind of. Our unit is very special. It doesn't really compare to a lot of NICUs, so it's kind of hard to compare. But another level 2 NICU may have a 1 to 5 or 1 to 6 ratio,
Wow.
and they could be more stable babies than we
Okay.
have. We have a mix of unstable and stable babies. We don't have 2 units. So every baby is in that one unit. So you could have an intubated baby with lines and a chest tube, and then also have a baby that's just working on eating. And that would be like your 2 patient assignment, or
Gotcha.
you can have 4 babies that are just working on getting bigger and eating, that kind of thing. And at a bigger, more intense, like strictly ICU, NICU, where they would have mostly babies that are getting cooling or babies that are intubated with lines, that kind of thing. Those would be a 1 to 2 ratio.
Yep. So the doctors in a NICU, they're called neonatologists, right?
Yes.
Okay. So I know in the ICUs for adults, it's basically like, yes, you do have the ICU doctor, but it's like because everything is so like tense, because everything is so serious, because this is like the ICU, right? Anything that happens that is a little that needs a specialist, you'll call like cardiology, or you'll call a urologist, or you'll call whatever you need to do. Are they neonatologist cardiologists? Are they neonatologist psychiatrists? Like, do you guys consult constantly like they do in the ICU, or is it basically the neonatologist that is taking care of most of the care?
Most of the time it is just the neonatologist.
Okay.
But we do have, whenever we find a specialized problem, such as something that is cardiac, then we will do all of the, like, if we have to do an echo, we'll get them to come in and do that. We'll do the EKG, all of that stuff, but they will read it. They don't necessarily come in to see the patient, like a cardiologist wouldn't come in to see the baby. They would just be consulted to read those specific imageries, and then our doctors would interpret it and like do whatever they want to do about it. But they pretty much take the whole picture. We do sometimes have to consult higher, different hospitals entirely for things that we think may be genetic. If it's a genetic type issue, we don't have like a genealogist just in our hospital. So
I don't think many do. I mean, you may have to work at John Hopkins if you have a genealogist on call.
yes,
Yeah.
yes. So we do have to consult other hospitals sometimes for things like that, but most of the time it is just our doctor, and they will just ask the other doctors to come in and maybe take a look at them to do one procedure, but they're not
Gotcha.
generally under the care of multiple doctors. It is just the one.
From your experience specifically, for babies that are not preemies, what is the most often reason they're in? Is it congenital heart defects? Is it patients with Down? Is it babies with Down syndrome? Is it just like low APGAR scores? What is the number one reason? I mean, you said multiple times feed and grow. Is that like the most like what causes a regular non-preemie baby to come to the NICU most often?
Most of the time, if a baby that is over 37 weeks comes to the NICU, it's generally because of something like meconium aspiration syndrome, where they've inhaled some of the meconium. It can also just be respiratory distress. That's like probably the number one thing that we see is respiratory distress, which is usually because of extra fluid that they
Mm,
didn't quite get out coming out. And a lot of times, I would say that's most common with C-section babies because they don't get squeezed as much coming out. So it
yep.
doesn't force them to expel a lot of fluid. And then they inhale the fluid, and then it becomes this whole thing, and they have to come up and get some CPAP. But other than that, it's pretty much just those two things.
Okay.
Occasionally, if a baby is older, if the mom had gestational diabetes, then a lot of times it'll be because of a blood sugar problem that they'll come up and have to get an IV just to maintain their blood sugar for a day or so, and then they wean it down and they can go back.
I know that
So
it's like, I don't, again, excuse the ignorance. I think it's like vitamin B. Like there's three medications that all babies get, right, when they're born, right?
we usually give them just the two, which is the erythromycin that goes in their eyes, and then vitamin K shot that goes in their leg.
Vitamin K. Um, if a baby's going to the NICU, do they get those shots or do you guys hold off? Do they get those meds or do you guys hold off?
We usually do give them to them because it
They still
helps them
get
with
it.
their bleeding and all of that. We explain what it is and everything before we give it. But yeah, I don't think there's ever been a time that we haven't given it that I know of while I have been there, that we haven't given it because of a premature age or anything like that.
And then this one is like, I remember being at the mother baby when my little guy was born. And they basically told me once I leave the hospital, anything that happens to baby it needs to go to ER peds, right? If you had a NICU patient, they were in the NICU 3, 4 days, they leave, they get home, something mom, dad, family thinks baby's not okay. Do they bring them back to the NICU or does the baby have to go to peds?
They usually go to peds. We did
Okay.
at one time, we were able to take readmits, but since COVID, we've stopped doing all that just because of, outside germs coming
Yep.
into the hospital. We don't want to expose all the other babies to that. So now, if it is under a month old, then our doctor will still be responsible for it, but it will be admitted to
Oh,
peds instead of our
I see.
floor. So they would still be doing all of the orders and everything like that, and then doing all of the care and everything, and they still go over to peds and see that baby, but the baby would not be admitted to my unit specifically.
So you sent me an article, a research paper on the stressors that NICU parents, NICU, I say patients because like the babies, they really, like you said earlier, the babies, they don't fight you on anything. They just struggling. They're just having a tough time their first time here on Earth. But
Yeah.
I really, really enjoyed this because it shines a light on this, on like the anxiousness, the anxiety that you were talking about earlier. But before I ask you, before we get into the article, because after the article, I think we could wrap this up, and I don't want to take your entire night over here. But before we get into the article, who are what kind of nurse or what kind of nursing student would you recommend become a NICU nurse? Like, is there in your head, do you think all nurses can be NICU nurses, or do you think it's a specific type of nurse that you think would not only become one, but thrive at being a NICU nurse?
It's so funny because we do actually talk about that a lot in my unit. We'll talk about the personality type of like NICU nurses, mother baby nurses, and labor nurses, because we have those are the three main units that I see a lot. But we'll talk about kind of the personality type, and everyone in my unit has a vastly different personality, I would say. We
Yeah.
actually are all quite different. But and it's very interesting because I would say a lot of the people that are NICU nurses are very similar to ICU nurses,
Yep.
how they can be like type A, kind of want everything, a specific way, follow the rules very carefully. And then we also have the other end of the spectrum. Like there can be someone who's just chill as can be, doesn't care
So
about a mess, doesn't care, about any of that. So we do have several ends of the spectrum, but I would say honestly, it's kind of more like you need to test yourself with whether you're okay with putting a needle in a baby's arm, really. That's that's the make or break test, because a lot of people cannot do it. They just can't even imagine doing something like that. And that's kind of where pediatrics also can steer a lot of people away, because especially if they're a kid that's like 4 years old, this is what steered me away from it. Was every time you walk in the room, they start crying because they know that you're there to do something mean, even though you're trying to help them. But most of the things that nurses do can be considered mean, because
Of course.
it can be painful, the things that we do.
Uncomfortable, painful, stressful, the whole nine. Yeah.
Exactly. So that's kind of what steered me away from pediatrics, was when the child would start staring at me and crying because they knew I was coming to do something bad. I was like, okay, yeah, I'm good with that. Whereas babies, they can flip. Like, they have no idea that you're the same person that just stuck their arm with a needle 5 minutes ago. And they'll just be like, oh, you're going to feed me a bottle? You're the best person ever. And they just change completely. So that's kind of what drew me more towards that, is that babies they just forget. They don't know that you just spent, an hour doing all this lab work on them or anything. And they just are content with being where they are. So that kind of drew me towards that. But I would say, yeah, people really need to just think about whether they're okay with doing things to a baby that would be considered mean. Really,
Yep.
that's where it kind of draws the line. I think I said something like that the other night to one of my coworkers, because we were trying to get an IV on a baby and it was not going easily. And I said, if my mother-in-law saw me right now, she would have a vastly different idea of who I am versus who she thinks I am, because it would be considered very mean. But
Yes.
it's what they need. So that's kind of where you get through it, is because you're trying to do something that they need. But I will say, yeah, NICU nurses can be vastly different personalities. But I would say overall, everyone in my unit is really good about putting themselves in the mother's shoes. So that's really what it comes down to, I think, is there's not a lot of people that feel that get like, when nurses can get burnt out and they kind of can be a little less friendly to some people during the daytime. That can happen sometimes. And I feel like in our unit, that doesn't really happen a lot. A lot of the nurses, whenever they do talk to the parents, they'll tell them, when I had my kid, I did this and that and the other, and they turned out fine. So I just want you to know that your baby's probably going to be okay. And they'll just constantly like put themselves in the parents' shoes or give them advice based on when they had kids or anything like that. So I think it's really just being able to put yourself in the shoes of the mother and thinking about how this is her baby, and this, you want it to be special and everything. And we also really like to do arts and crafts. I think almost everyone likes to do arts and crafts in my unit.
I love
we
that.
do a lot of baby
You have to,
footprints.
you have to be able to put IVs in babies, empathy, and arts and crafts. Arts and crafts
And
is
do arts
support.
and crafts. Yes.
It's not a
Because
bad list.
some people really think that most of the time, a lot of times we get that people think that all we do is like dress the babies up and cuddle them all day. And I mean, I'm not gonna lie, we do dress them up and cuddle them sometimes. And we do make footprints for them. I made a Winnie the Pooh footprint the other night. That was little
Aw.
Piglet and Pooh next to each other. And we do that kind of stuff, but we really do it to show the parents that we care. It's not just because we like to do it, it's because it shows the parents that we aren't just trying to do mean things to their baby and keep their baby from them. We actually care, and we understand that this is hard. And those are all things that they'll remember forever. But it's just strange because, yeah, we do mean things, but then we also will dress them up the next day. So it's
Of
kind of all over
course.
the place.
It makes sense. It's being in the hospital. I mean, you can do as nice other things as you want. But at the end of the day, the patient is sick, the baby is sick, right? Or
Yes.
is not as healthy as they need to be. So the mean things are necessary. right? The mean
Yes.
things are
Yes.
necessary. Uh, one major thing in most hospitals I've worked at, when the med surge tele floors, when the non ICU floors need help with IVs, they call the ICU nurses. I can't imagine how good a NICU nurse must be at IVs. You guys must just be throwing needles at people, right? Because I mean, that's usually the progression. It's like, especially when you work overnight, because most of the time there's no IV team. You call an ICU nurse, the ICU nurse comes down, they attempt, and if they're unsuccessful, it's like, oh, we're gonna have to wait till tomorrow when the IV team comes. So I bet you guys are on point with your IVs, even though it sucks doing it.
Yeah,
Um,
we do. It's very interesting because we will have mother baby nurses that like bring a baby up that needs an IV or something, and we'll
of
start
course.
looking at it and we'll be like, "Oh, look at that. That's a good one." And they're like, "What are you looking at? I can't even see what you're looking at." And I'm like, "No, it's right there. It's that, see that tiny little like angel hair spaghetti right there? That's it." And they're like, "Are you serious right now?" But we do, yeah, we do get called by other units to come and help them with IVs as well. It's usually not on adults. Most of the time it's pediatrics calling us, or sometimes the ER will call and say that they
Yeah.
want us to come and try on a child that they can't get. And I did that a couple of months ago and helped them get that. And of course, it blew right after that because when you have a 24 gauge catheter, you can only run so much fluid through it.
um, and I think a lot of what we talked about, I think the this paper that you sent me is it, it explains a lot of what we were talking about, and I really want to know your perspective on a lot of this. So this is the neonatal intensive care unit environmental stressors and support. This paper is basically talking about the stresses that moms, specifically families of the babe of a NICU baby, suffer or experience when they are having a baby go through the NICU. So just to give you guys some numbers out there, nearly 7% of births in the US result in infants who require to go some degree of the NICU. 15% of mothers and 8% of fathers with premature infants admitted to the NICU experience postpartum PTSD. That blew my mind. PTSD, right? That's insane. And not only that, ladies and gentlemen, between 39 and 63% of mothers with NICU infants experience postpartum depression. So when you said that, I know that we were talking about something else when we talk about the stress levels are higher these days, but the stress levels for family members, moms who have babies go to the NICU are through the goddamn roof, right? So just like it's insane. They just did the hardest thing physically they've ever done in their entire life, give birth, and now the all of that stress, the 9 months of stress that they put into creating this human being comes out of them. They're exhausted. They're in pain. They're about to pass out. And then you take the baby away to go to a NICU. I can't imagine. I can't imagine that kind of stress, right? So that's why in the beginning, I wanted to talk about the emotions, because it just seems like the perfect cocktail to like, like just to really break someone down, right? Really break someone down. But the research that they did was to find out what are the things that causes this already very stressful situation to worsen. And they came out with 5 major points. And I want to just go down one at a time, and then you tell me what you guys do to help soften these stressors, or what you guys do to mitigate it entirely. So number one, the amount and quality of communication with medical staff. I know you mentioned it earlier about how you explain basically everything you do. You want someone to come with you to see what's going on, but this has to be huge. This has to be huge. So please tell me, how do you communicate the NICU aspect to these new mothers to make sure that this isn't adding to their stress?
We really try to tell them everything that is going on. And we also explain what we would expect from a baby of this gestation so that they know kind of the benchmark that they should be measuring against. And we will tell them, if this is something that we see a lot, or if this is something that we don't see a lot, but we are still dealing with. I feel like that really helps them, because a lot of times when we get a baby that is premature, we can figure out pretty quickly if they have some unrealistic expectations of what they think the baby should be doing. And that's usually how we can tell that maybe they didn't get a full talking to the first time they came, something like that. If they're coming in and the baby is 32 weeks and they're like, oh, okay, so they can come home next week. And we're like, no, I don't think so. And then we have to explain, what we would expect from a baby of this gestation, what possible timeline we have of them going home. But generally, we try not to focus more on a timeline. We try to focus on goals. And so we tell them the goals that we want the baby to achieve in order to go home, such as maintaining its own temperature without being in a warmer type of bed, and being able to gain weight, and being able to eat all of the prescribed amount of food that it's supposed to eat without needing any kind of tube feeding or anything like that. And maintaining its blood sugar. And especially if it's like on oxygen, we'll explain generally the cascade of events that we will expect. So if a baby were to come up that's on CPAP, generally they're on CPAP, they have an IV, they're not eating yet, and they're usually under a warmer. And it depends on their size, but if they were under 4 pounds, let's say, then they would be in a warmer and all of that. So we'll say, usually we would expect that the baby will probably come off of the CPAP first within a couple of days, hopefully, but sometimes it can be longer. And then we'll expect that we'll be weaning the IV out, and then we'll be trying to give them milk of some kind. And hopefully they can try to take it by mouth, but if they can't, then they may need a tube feeding, and then they will try to wean the warmer down, and it will take approximately this long, hopefully. And we give them all of the goals that they need so that they can start checking it off the list. We usually tell them it's like a checklist, like this is what they checked off first, this is what they checked off second. And we usually try to tell them something that they've already done to kind of get their spirits up, that
Yes,
they've already achieved something. Like
exactly.
especially if they come up just on CPAP, we'll be like, well, they're already breathing on their own. They just need a little extra support. That way they know that the baby's actually doing okay and is doing something they're supposed to do. They just need a little help. Something like that usually will kind of calm them down, and they'll be like, oh, they're doing so good. They're such a tough fighter. And I'm like, yes, yeah, they're really
Exactly.
trying.
Exactly. Um, the thing I love that you said is you don't want to give timelines, you want to give goals. And this is not only for NICU or ICU, this is for all kinds of nursing. The second you give a timeline, if you don't hit exactly that timeline, everyone gets really pissed really quickly.
Yes.
So I love the fact that you mentioned that. You don't want to ever tell a patient you are going to go home in 2 days. Because if they don't, that's a much bigger problem than telling them, it usually takes 2 days. We'll see how we're going. This is how long we expect them. This is the goal we're trying to reach before you are able to go home. Because then they know what they need prior to going. But that's huge. That's huge. Before I go on to number 2, because a lot of the stuff has to do with communication, and a lot of the stuff has to do with mom not being able to be with baby. What are the visitation, not requirements, but what are the visitation rights of the mom to be with baby when baby is in the NICU? On average, because I know it depends on how sick the baby is, but like on average, how often can the mom, like how many hours throughout the day, or however you guys decide, but what are the visitation rights?
They usually don't really restrict anything. It depends on the unit that you're in, because some have certain time periods throughout the day that they do, like, for example, all the sterile line dressings might get changed at a certain time, and they will shut the entire unit down in order to do that. My unit doesn't generally do that. We have a pretty open policy. So we basically, the parents can come anytime, day or night. They can come however often they want. They can spend hours sitting there. We've had parents come that are just like reading a book at the bedside, just sitting with the baby for a couple of hours, that kind of thing. So there's no real restriction, but we do, when we can see that the mom is coming more than what we might expect for the first day or the first 2 days. Generally, we'll expect them to come maybe once a shift, and that would be pushing themselves pretty hard. But
Yeah.
if they're coming like multiple times every shift, usually one of our nurses will say, hey, you need to take care of yourself too. Don't worry, like we've got the baby. Now would be the time for you to get some rest while you can, and make sure that you're staying healthy, because if you go down, then it's going to be twice as much stress on you and on
100%.
potentially your partner or whoever's there with
Family.
you,
Yep.
because then they're stretched both ways. We've had
Exactly.
parents before that, yeah, when like the mom is really sick and the baby's really sick and the dad is just like caught in the middle, they get really stressed out. So we try to tell them,
Of
if we
course.
notice that they're coming a lot more than we would expect for their recovery time, then we will usually tell them like, hey, it's okay if you miss this next feeding. We will make sure your baby is fed, but make sure you get a good nap in or something. And then you could come back the next time or something like that. But we never will like make them leave ever.
Of course.
We
Of
just
course.
will say, hey, you can come whenever you want. And I usually tell them like, come back whenever you want, just come and see them. And if you can't make it, you can always call. And that
Exactly.
usually gives them some comfort, because I'll be like, here's our number, call us and I'll tell you exactly everything that happened with the last feeding or something like that. So I feel like that helps them too. But we have a pretty open policy as far as the parents coming. The visitation like with other people is more strict than that. So
Of
usually it's
course.
just open to the parents.
Number two is very closely related to number one. The things that add to the stressors. It's bedside manner of the medical staff, and I just want to give you an example of what one of the participants in this research study had said when talking about how the bedside manner can cause more stress. She said, I was reprimanded rudely when I came back from lunch to find my baby had spit up on herself and pooped her diaper, and I changed her and cleaned her up in between her feeding time. Not okay. Some RNs are quite rude if you're not getting enough breast milk, don't have enough. And I know you just said like sometimes you can do the feed, sometimes you can do, like you have to shut down the entire unit, right? So when she says she changed the diaper because her baby was messy, and one of the nurses at the time was very rudely telling her, this is not okay, you're not allowed to do that. I know when it's like, if you guys are doing your sterile line cleaning and a patient or a mom were to just walk in and mess things up, get in the way, it would be very stressful. I understand that would be very stressful. But I know you were talking to me about the communication. Is there anything specifically you do when when you are dealing with a difficult patient, when a difficult parent, mom or dad or extra family member? How do you not have that negative bedside manner, but at the same time putting your foot down and explaining to them this needs to happen or the baby will be not well?
Yeah. I will say that's one thing that I was going to mention earlier when we were talking about the type of nurses that would thrive in the NICU. You have to sometimes also be able to put down your foot. So there are some parents that can come, and we, encourage as much bonding with them as possible. We want you to bond with your baby, but sometimes there are times that it's not always the best for the baby at that time. We do have sometimes babies that we call minimal stimulation babies, and those are ones that even if we just wake them up to change their diaper, for example, which most of the time if there's like barf everywhere and poop coming out, you can change the baby's diaper because yeah, it needs to be changed. And but we do have sometimes babies that when we do things like change their diaper, simple task, they will wake up and they will drop their oxygen saturation and not be able to come
Ooh.
back up for 15-20 minutes until they calm down. So there are babies that are like that when they're really sick, they do tend to be more irritable. And so there are babies that sometimes we will tell the parents, like, please don't touch them when you come this time. But if you want to wait, we will tell them exactly what time, like, we are planning to touch them and do all of their care so that they can come during that time and they can touch the baby and they can help change the diaper and that kind of stuff, because then they can bond with the baby. But if they come, let's say, I had a minimal stimulation baby that I did at 8 o'clock, and it's not due again until midnight, because sometimes for those types of babies, we may do like a hands-off set of vitals at 2 hours in the middle, so that we only touch them every 4 hours instead of every 3 hours like we typically would, because of the minimal stimulation that they need. If I did my time with them at 8 o'clock and then the parents come at 10 o'clock and start touching the baby's back and touching its feet, and then it starts desatting, and then it's awake for 30 minutes, and then I have to touch it again at midnight, it's not getting the rest that it needs to heal. So there are times that we do have to tell them, like, please don't touch them this time, but if you want to come at this time, they can be touched, and maybe you could even do skin to skin at that time whenever you come. If you would like to stay and do some skin to skin, that might help them, or something like that. I usually try to encourage them, like, hey, this is the next time that would be a really good time for you to come, or this other time. And I'll give them multiple options and say, hey, if you want to come back this time or this time, that's good. And I will still update them on the baby and tell them, like, the baby's doing okay. We're trying to wean the oxygen down, and she's been asleep for the last 30 minutes. And we're trying to just make sure that we keep everything dark and really quiet so that she doesn't wake up, that kind of thing. But I will say there are times that we do have to kind of have a talk with them, because sometimes there are always family members and patients and everybody who just won't listen.
Of course.
So sometimes there are ones that will still continue to touch the baby. But I wouldn't say that there's ever been a time that we've like had to do really anything about it. Pretty much we just talk to them about it, and then they will start to listen and calm down.
Do you guys have like a locked unit? Or when family visit, can they just walk into the NICU, or like you have to be like buzzed in and the whole nine? Because I know like the pink alerts and stuff, like baby units are pretty locked down, right?
Yeah, we are locked down fully. My unit is completely locked.
Okay.
There's only a few entrances, and we do have like a buzzer button
Exactly.
that we can push for them to come in, and they have to provide like a patient identifier for them to be able to come in. And we even get their temperatures before they come in once a day, that kind of thing, to make sure that nobody's having any kind of illness. We'll screen them and make sure they don't have any kind of respiratory illness that they could potentially spread to other babies and that kind of thing. So we do make sure who's coming in. We know every person that's coming in to the unit.
And this, like, the thing that really did what you said, that like just as a new parent that would just like break me, is if you told me you were not allowed to touch, if you told me I couldn't touch my baby, like that's such it, like, just I'm getting emotional just thinking about the idea that someone could be like, don't touch the baby, right?
No.
So like just it's just I can see, of course, this would add to the stress, but I can see how, and specifically nowadays, it's considered, I don't want to say that people think that hospitals are like hotels or it's customer service, but it's a very different thing, right? It's someone else's life. Yeah. And like, we're not trying, yes, we want the best bedside manner, but some patients can't see a no or something like don't touch your baby as bad bedside manner, but it's also a necessity. It's also a necessity.
Yes. Yes, very much so. And I will say that's one of that's a lot of the pushback sometimes that we see. If we ever see a form of aggression, it's usually something along the lines of, you're not going to tell me what I can and cannot do to my baby.
Exactly.
That's usually the kind of aggression that we see. And pretty much at that point, we'll usually contact a higher up to come and talk to them, because we have explained to them why it's not bad, why it's not good for the baby, that kind of thing. And usually though, like the first time they come up, we'll just let them, especially the first time they come up, we'll be like, you know what, go ahead and touch, and we'll deal with it after the fact. But just for future reference, this time would be a good time for you to come. So most of the time we wouldn't restrict them like the first time that they come up ever, but we will, unless they're really, really, really sick, in which case we will explain to them before they even get to the bedside what is going on with the baby, and say, hey, I want you to look at this. This is what's going on. And I'll give you a generalized time of when I think would be a good time for you to come and touch the baby, or come and see the baby, or something like that. We try to offer them some kind of like olive branch to say, hey, I'm going to do the care at this time. If you want to see the bed open and take some good pictures of the baby, that would be a good time to come, like that kind of thing, so that they kind of get something.
So I think the stressor number three, I think we've covered. So I'll just say it. The stressor number three in this research paper was feeling alienated from the infant's care. And I feel like you've touched upon this quite a bit. Is there anything else you wanted to add, like that you guys do specifically for this stressor for moms? Or do you think
I
we've
feel
covered it?
like I understand like that stressor, because a lot of times we do just kind of like do the care on the baby, and then the mom comes in and we're like, oh yeah, I just changed her diaper and I just fed her and now she's asleep, and you've just come in, it's 30 minutes after she ate, so there's nothing really for you to do. But we never would say that specifically to them. But we whenever a parent is there, I will usually try to give them the option, and I'll say something like, do you want to change the diaper, or do you want me to change the diaper this time? And that way they have something that they can do, so they feel like they're still participating. And I know that that's a big thing, is participation in their care, so it helps them feel like they're getting bonded. But I will say probably 7 times out of 10, they tell me to just change the diaper so that
Yeah.
they can just watch the baby or something. Or they'll say, oh, the dad can change the diaper. And then the dad's like, okay.
uh, the thing of the thing about the feeling alienated, it does suck, right? Because babies very differently than adults. It's like, yeah, let's say, okay, the plan is we're going to feed baby every 3 hours. But if the baby wakes up 2 hours and mom isn't here yet, you can't just be like, baby, you have to wait. Your mom's coming. You kind of have to do the thing, right? Like you have to do the care. So if mom comes and she's like, but you told me, and it's like, I know, but your son, your daughter, your baby just woke up and screaming very loudly. So I did the care. I had to do the care.
Yeah,
So I
we
can
do
understand.
that sometimes.
Yeah. So it is really frustrating, and it's really tricky, especially when it comes to the NICU. This one I thought was super interesting, and I want to know if this is something that you guys do regularly. Support from other NICU moms and babies. NICU moms and babies. NICU moms and families. Do you ever have patients talk to other patients that both have NICU babies in the facility in your unit? Is this something that you guys have, like, I don't know, like a NICU group in our group that you like give information for parents, or is this like not something you guys do? Because when I was at the hospital, they give you these pamphlets with like websites that you could go to and like meetings that you can go to, but I never saw any nurse being like, here's another mom going through very similar things. Do you guys want to chit chat? It just feels like a really busy and stressful time to say, maybe you want to talk to someone else. Is that something that you guys do at all?
We don't have like a specified group that we would say, hey, maybe you should. We don't do it for every parent, I should say that. Like, there's
Okay.
not like a group that we just broad spectrum say, hey, your baby's been in the NICU, maybe you'd be interested in this group kind of thing. But we do sometimes, if there is a specific patient family member that is struggling, and we can see that they're struggling really hard with some kind of diagnosis or something like that. Occasionally, our doctors will, if they know someone who has a child with the same thing, or they know someone who, experienced something similar, then they might offer to the parents, hey, do you want to maybe talk to this other mom that I know? And she can kind of give you advice on how to handle this kind of thing. So they do kind of try to do that every once in a while. And we also sometimes, if we have a baby that stays for a really long time, that we're expecting to stay for a long time, we do have, it depends on where the parents live, but if they live a certain many number of miles away from the hospital, there is a place where they can stay that's at a neighboring hospital, and they can stay there for like a minimal fee per night, and that is all NICU parents.
Oh,
So a
I
lot
love
of
that.
times, if we have parents that the baby is going to stay for a long time and they're staying over there, they'll come into our unit and they'll be like, yeah, so I met this other mom who was talking about her baby, and her baby is like even younger than my baby, so I feel like, we're doing okay. And you can tell it really does help them. I wish we did have like kind of a standardized group, but we don't have one that we currently like endorse or anything.
Yeah. The fact that you said it in the research paper, it says the exact same thing. Many of these moms, especially because they're like, yeah, I want to go home, but I also want to be able to come to the hospital very frequently. So they get hotels really
Yeah.
close to the hospital. And a lot of the time, the hospital is sponsoring and giving them a very, very, very cheap price to stay at those places. Piper, 10, 15 more minutes. Are you okay with that? I feel like I've been
Oh
taking a
yeah.
lot. Okay,
Oh
good.
no, I'm good. I'm just chilling. Don't have anything else I need to be doing.
You're the best. Thank you. So, I just want to read this conclusion from this paper because I think this is super important. All right. It says here women who exhibit higher levels of stress interact less. Women who experience higher levels of stress interact less with their infants in the NICU. That surprised me because if you read the paper, it's a lot of the stress is caused because mom can't interact, mom's not understanding, baby's taken away from mom, mom doesn't know what's happening with the baby, so to find out that the stress caused them to interact even less than fight to be in with baby even more is really scary. It's not scary, but it's shitty, right? You can't be with baby, it causes you high stress, which makes you want to be with baby less. I think is just the NICU is a scary place.
Yeah, that's
Continue
very
on,
surprising.
right? Like that's what I thought when I read that. I was like, wow, that's actually crazy. One major implication of the study is that these themes are not mutually exclusive. Good bedside manner cannot be practiced without effective communication between patients and medical staff, and effective communication is necessary for mothers to feel included and not alienated from infants' care. So you could see that's why I was saying to Piper that she's touched upon all of these things prior to us even talking about the research paper because you can't do one without the other. You can't help a mom not feel alienated if there's no good communication and if there's not good any bedside manner. So they're all melded into one. So it's hard to separate them specifically. But Piper, I just thank you so much. Just thank you so much for answering and going through with me. And then on top of that, this is a great research paper. For those who are watching, listening, there'll be a link in the comment section, down description box, wherever you'll find it. It'll
Yeah.
be with yeah. But it was really eye opening, and going into the NICU, like I said in the beginning, is a stressful situation. So if you are a NICU nurse, if you are working in the NICU, anything you could do to lessen the stress would not only help the mom, which obviously is necessary, but would help the baby because a stressed mom is going to spend less time with infants. Stressed moms are going to spend less time with infants. That right there is just like key.
Yeah, it's
Two
very, very crazy because I never would have, you wouldn't expect that. A lot of the, I
exactly.
should say, the anxious people that we see, they do come a lot, but there are some, most of the ones that we see struggling the hardest are the ones that withdraw. And those are the ones that generally will be like, hey, do you want to talk to somebody else who has something similar? And those are the ones
Mm,
that we generally will focus on more because we can tell when they haven't come to see the baby for several days that something is going on.
yep, yep, yep. I want to talk about a shitty like news topic that has to do with the NICU, and then I want to talk about you as a NICU nurse, like human being outside of the hospital. So it's just a news story. I know this happened about a month ago. There was a Long Island hospital nurse that was fired because there's a disturbing video of the dad that was recording the baby in the NICU. There was like a sheet, but like it was open enough where they could see the baby, and the NICU nurse very roughly, if you the article, the news story says that the baby was slammed by the NICU nurse. If you watch the video, it's like
Yeah.
so hard to watch. So you know what story I'm talking about?
Yes, I saw that.
Yes.
I saw that video.
Please, just thoughts. I'm not trying to break it down, analyze anything. Just thoughts about that story when you first saw it or first heard about it.
Well, when I first saw it, I was kind of like, what severity are we talking about? Because there are different severities of everything. Not that anything should ever be excused like that. But I will say that there are some things that we may do to a baby that would be considered rough. Um, for example, if we have to do like a lumbar puncture, I have had to curl a baby almost in half and put most of my body weight on it to hold it in place. And that would be considered, I mean, that I would consider that rough.
Of
But
course,
in
of
order
course.
yes. And it's not something fun, and like holding their arms straight when we need to get an IV, those kinds of things. If you were someone who didn't understand that that was necessary, I could see it being very, very traumatizing to watch those kinds of things. And generally, that's why we don't let parents watch those kinds of things, because it can be very traumatizing and it can be what would be considered rough. But I do think that there was not a reason to
In that
be like
video. Yeah.
that. Yeah,
Yeah.
in that video, there wasn't any kind of reason other than maybe the nurse's frustration at that point, and she just had enough or was burnt out. I'm not sure, but yeah, that would be a scenario in which you need to take yourself to the break room, or just leave for a minute, get your breathing, and then go back out there with a fresh mindset. I mean, I will say there can be a lot of frustration in the NICU with the nurses. My unit is very open, and like we don't have, for example, like a normal unit would have like pods with the rooms. And so you can close the room doors and sit at your computer and chart. We don't have that. So it's like your computer is in the middle of your patients, and your patients
Oh,
are surrounding
shoot.
you. So if you have two babies that are screaming, because, for example, babies that withdraw from drugs, they scream a lot, and
What is
there's
that? It's
not a
the
lot you can do.
NAS. What is it called?
Yeah, NAS,
Yeah,
neonatal
those.
abstinence syndrome.
Mm.
Yeah, we will see those frequently, and those can be a high stressor on the nurses, because when you're sitting there in between four babies and two of them are screaming at you for over 6 hours, it's like overstimulation, and you can get so flustered and frustrated, and you're trying to do everything, and sometimes there's babies that you just can't help. And that's one thing we have to explain to other parents too, when they'll hear a baby screaming for a couple of hours, and if it's something like NAS that causes them to scream an abnormally long amount of time and quite shrilly, that's one of the things that they do. They
Exactly.
scream a very shrill scream. Sometimes we will have to explain to the parents, like, without saying what is going on, we'll just say sometimes there are things causing babies to scream that we can't fix. And
Gotcha.
so you just need to kind of excuse it, because you will see a parent give us kind of a dirty look, like, why aren't you going over there? That baby's screaming.
Yep. Yep.
But when it's been
Yeah.
screaming for 6 hours and four nurses have gone over there every 15 minutes to try to help the baby, and there's nothing we can do for it,
Yeah,
it's like,
me staying
there's
in
nothing we
next to
can
yeah,
do.
it's not going to help. We
Yeah.
don't get that often, but we have patients with dementia that are screaming like bloody murder all the time, and it's like when when a family member or another patient's like, "You guys are killing this person," it's like I can't tell you what's happening, but I can tell you we can't fix this. Right? This is something we can't fix.
Yeah. That's when
Um,
you might be thankful for a door to just kind of like
exactly. Just
hush it a little bit,
please.
but we don't have that option. So they're just screaming at you. And a nurse has to be on the unit at all times. Like, we can't just all go to the break room and take
Yeah, there's
our
no way.
time. Someone has to stay out there and listen to it while someone else gets a mental health break. So, I feel like it is an environment that could be also very stressful and very overstimulating. That's what one of the nurses I work with describes it a lot as, is overstimulating. By the end of your shift, you might be just like, you really want to be in a dark, quiet room for a while, because you've had babies screaming at you for hours and hours and hours. So it can be a frustrating job, but yeah, that video still shocked me, because I was like, okay,
That's
we
insane.
need to not be doing
Yeah,
that. That's for
exactly.
sure.
Um, for those who don't know, that the nurse was fired. I don't know if any charges were being pressed. The article I read came out like February like 30th, February like 20th or something. So I don't know if any charges were pressed. The nurse was fired, and the baby's name is Nico. Baby Nico is healthy, no issues, home, happy with mom and dad. So the personal questions, the outside of work NICU nurse questions that I had for you is the perfect transition. What your nurse buddy said about the overstimulation. When I was prepping to, becoming a new dad, all of the books I've been reading, what to expect, and your baby crib sheets, and all of these good books about taking care of baby. It says that, and I'm paraphrasing, I don't know the exact statistics, but like the decibels, or like that shrilly scream that when babies are really like screaming and crying. I have a healthy young baby. I mean, very healthy, great baby, not colicky, not like nothing crazy. Like, I'm like, knock on wood, greatest baby ever. Um, but even with his cry, it gets to me, right? I cannot imagine, Piper, 4, 6, however many babies you deal with. That overstimulation is an understatement. If I'm dealing with my baby, not a sick baby, my baby who's healthy, happy, the whole nine, that is home with me, and they have that shrill cry, I am so stressed. I am so depleted. How do you not burn out? How do the nurses on your unit not burn out? How do you take care of yourself? I know you said you take that few minutes in the break room, but like actually outside of work, what, like, do you have like a massage chair in the break room? How do you not like just rip all your hair out when you're hearing that all day, all night?
I will say that we generally deal with a lot of things, like a lot of nurses do, with humor. So we deal a
Yes.
lot of it with that. But I don't know why, but I actually really like the ones like the NAS kids that scream a lot. Those are some of my favorite babies to take care of. And we will come up with other things that we can try to do to minimize the amount of screaming. But if we can tell that someone is like, we're very vocal with each other about if we need some time to just decompress for a little bit. And the chargers will usually be like, okay, yeah, you go get you a break. I will do this baby for you. And then when you come back, you'll be reset and everything. But we have a massage chair in the break room. I can't remember if it works anymore.
Oh
It's been there.
no. You talk to your manager.
It's been there for a while. It was a gift actually from our doctors from years ago before I even started. And it's kind of, I think it's hit or miss. Sometimes it works, sometimes it doesn't. But we do have that. And our break room is pretty far from our unit, so you can't really hear
Okay.
like
Well,
the
that's
babies
nice.
or anything screaming
So it's like a
if
real
you're in the
break.
break room. Yeah, it's a real break. And we usually even like, and I will say that's kind of one of those things that we just do on my unit as like, it's like an unspoken kind of rule, is that we usually take our lunch breaks alone. So most of the time, because my unit is really small, we will kind of time our breaks so that someone will go, they come back, someone else will go, they come back, someone else will go. And that way we get our time to just be by ourselves, decompress. We're not talking, we're not chatting, because we also spend, I mean, I will say, we got to be some of the closest nurses ever because we spend all shift in one large room together.
Yeah.
So there's no escaping each other. We are constantly all together. And so our escape kind of from everything, I think, is to go and take our lunch break alone. Sometimes we'll still take it together if there's so many people working that it's not going to work out for everyone to have
Yeah.
theirs alone. Then people might take it together, but they kind of just like sit there in the quiet most of the time and just kind of decompress. And so we do that, but also like everyone on my unit is really close. So everyone will get together like outside of work several times a year. We'll have like a little party where people get together, or have a lunch where a couple people get together. And I feel like that kind of helps because then we also get to see each other outside of the babies screaming at us and discussing work.
Yeah.
And so we can talk about anything else. And it's not as stressful of an environment when you're just like out to lunch or whatever. But we do. And I think the doctors even gifted us like a massage gift certificate last year.
Aw.
So they're keeping up with it too. They know what we want. And so they will give us stuff like that for Christmas, that kind of thing, so that we can decompress. But also sometimes we'll just work together as a team, and we do the potlucks.
Yep.
If you do a potluck at work, your night is already good. It can't really go
Exactly.
that bad.
No, yes. Bring them goodies. Bring them goodies. I love it.
Exactly.
I love it. I love it. I know you work night shift. I ask this question just because when I see nurses that I don't know, I feel like you're doing your job. I've never worked with you, obviously, but um, you, when I see someone who's proud of being a nurse, the assumption I make is that they're fairly good at it. You said that you're a charge nurse. You've been doing this for 5 years. It sounds like you really like your job. I'm gonna assume that you at least know what you're doing, if not good at it. So I ask this question. If it's too much, by all means. But do you have a morning routine? How do you prep yourself for a good day?
For my shifts,
Yeah,
or
like
like a
how do
good
you
day on my shifts.
exactly like what do you like? What does your morning routine look like from like the time you wake up or from like, when you're getting ready? Do you have a specific thing? Do you need to like get your coffee from this place? Is this specific? Like, what does your routine look like so you're prepped for a good day?
I pretty much, our cafeteria is not open at night. So I
Mm,
have to bring a lunch every single night. And so I always make sure that I get up and I kind of like get myself ready to go before I come out and like let my dogs out, that kind of thing. And they usually wake me up because they're so excited. And then I almost always make my coffee at home because I know that whenever I try to stop somewhere on my way to work, it makes me almost late
of
every single
course.
time.
Of
So
course.
I just can't do it. So I just make my coffee at home and then I drink it on my way to work, and I almost always bop to some music on my way to work. And then on my way home, I'll listen to an audiobook, which will help me like kind of wind down. But on my way there, I'm like blasting some music so that I can get myself
Let's go.
pumped while I'm drinking my coffee. And then I'll just walk up there and I, of course, like a lot of nurses will just wait until I know how many minutes it takes me to walk to my unit to be able to
Yep.
clock in on time.
Yep.
And I'll wait until that time and then I'll walk into the unit because I know if I walk in early and it's crazy, I'm going to get roped into something.
Of
So I
course.
so I'll just wait until I'll take a few minutes in my car, then I'll get my stuff, and usually me or another coworker will see each other on the way in and we'll talk. And our little routine is like, how many babies do we have? I don't know. Do you know how many babies we have? And we'll just like talk about what we think is going on the unit that day. But every day can be so different. And then once you
Yeah.
walk in, you never know what it's going to be. It could be like the best night ever, or it could be just like wild from the get go and never stops. It's always something crazy. But at least if I've had my music and my coffee already, I'm like,
You're
it's going to
moving.
kick in here in a
Yep.
few minutes. Make sure I eat something before I go because sometimes you never know when you're going to eat again. But most of the time, it's we have I have so many snacks and stuff that I'm able to get something whenever I need it. So it's really good. But
Are you always
there's
charged
nothing
now or
specific.
sometimes are you always charged now or sometimes right now are you staff, just one of the nurses?
This week actually I was charged once and then I was staffed twice. So
Okay.
I'm just kind of like I used to be charged a lot more, and we got some more like even more experienced nurses in. And so they're trying to rotate like who's charged
Charge.
because we did only have um three charge nurses at a time. So me and two others. And so I was being charged pretty much every week
Basically. Hmm.
for a little while. And then if one of them went on vacation, then I was charged like every shift for that week. But now we have several people that we're rotating through. So everyone's getting like there's two that pretty much are always charged. And then there's several that will get like one shift a week, maybe that we're charged. And
Do
they'll
you have
just
a
kind of
preference?
rotate it through. I actually don't really have a preference. There are certain nights that I would prefer to take patients, and there's certain nights that I prefer to be charged. Our charge nurse does a lot of stuff that not necessarily every charge unit would do. Like for example, we clean all of our own equipment, and most of our own bed spaces, especially at night.
Wait, what do
So
you mean? You
like
guys don't have
the
housekeeping come
isolette
clean up?
and the beds, like the big isolettes that the babies are in. Whenever they get moved from that to a different type of bed, we are responsible for cleaning it. Housekeeping doesn't know how to clean those. So
Oh
our unit
wow.
specifically, we clean them. And then our radiant warmers, we clean all those, all the bassinets we clean. all of the feeding pumps, IV pumps, all of that stuff we clean. Occasionally we will call to have them come and clean like a bed space for us, and basically they just like mop the floor and wipe the walls down. But most of the time, rather than wait for them to come, we just do it ourselves. So our charge nurse does a lot of cleaning, and we do all of our own laundry too. All of the like baby fancy
Piper.
clothes that we have, we do all of that laundry on our unit. And so our charge nurse generally does that. And then we do all the restocking, and our charge nurse also attends all of the high risk deliveries. So if there's a
Oh
baby
wow.
downstairs that they
Wow.
think is going to be premature, then they go with the doctor to the delivery to bring the baby up to the unit. So
Is this also the same for day nurses, or is it mainly night nurses because you guys don't have like the like EVS or central supply to come up and supply, and like housekeeping to come and clean? Is it less staff so you guys just end up doing it, or is this something charge nurses or the NICU nurses do regularly, day or night?
no, it's actually day shift also does it all as well. They do all the
Damn.
cleaning, we do all the restocking. We do have a central supply room, but it's towards the back of our unit, which is pretty far from the babies. And so we have our formula preparation rooms where we prep the milk and stuff. And those we have to take the supplies from the supply room and bring them to the formula rooms so that it's more convenient for the nurses to use rather than walking like a mile every
Yep.
day back and forth. And also you'd have to make sure that someone's like in the unit while you walk back to the supply room. So we
Jeez.
just restock everything, and then we have our own linen carts on the unit. Basically they try to keep as much outside like hospital personnel towards like in the unit the least amount. So our
That does
linens
make
get
sense though.
restocked. Yeah.
Okay.
So our linens
Yeah.
get restocked to a specific room that's very close to the outside door. And then we take those linens and put them in the main part of the unit. And
Okay.
same with the supplies and stuff like that. So environmental will come and they'll clean bed spaces, but they generally don't clean any of our equipment. So we clean all of our own equipment, even on day shift and night shift. And day shift will
So
also do rounds with the doctors and
yeah.
all that kind of
the,
stuff.
the the rationale behind not having non-medical or any staff that doesn't need to be in there that does make sense, but like Piper, you got to talk to your boss. You guys all deserve raises. That's more work than any hospital I've ever worked at, any position, telling me that I need to clean and restock on top of care for my patients. Get out of here. It's insanity. It's insanity.
Well, they do have us, our charge nurse is generally a free charge nurse
Okay.
because of that reason. So they make our unit like a priority to have a free charge nurse, because the charge nurse is kind of on call for all of the units. So like if peds needs help with an IV, the charge nurse goes. If ER needs help with an IV, the charge nurse goes. If labor has a high risk delivery, the charge nurse has to go. If mother baby has a baby that they think is sick or isn't breathing well, the charge nurse has to go. So because she's kind of on call for everyone, they try to never
Make
pretty
sure.
much give her patients unless
Okay.
it's absolutely necessary.
Makes sense. And like you have said that with the high risk deliveries that the charge has to go. So it does make sense. You can't have a charge nurse have a NICU patient and then have to also go to these deliveries on call. That would be a lot.
Yeah, sometimes they do, but they'll usually, the other nurses will like watch out for their patient while they're going to do whatever they need
Teamwork.
to do. But we have a priority of things. So like restocking maybe lower on the priority list on a certain day if it's really busy.
I'd
It's
hope
just like,
so. I'd
if
hope
we
so.
run out of stuff, somebody grab a big pile of it and bring it out. And then we'll work together on it.
Teamwork makes the dream work. Last
Exactly.
question, and this is last couple of questions, but this is a very personal thing. On your Instagram, where I found you, where I reached out originally, is you have I don't know what it's called, like a memory section of books. Quite a big reader. You seem to always have a book in your stories wherever social I see you. So just 3 questions. You can answer any of them, all of them, however you want to go through it. Number 1, what is the most gifted book that you gift other folks. Book that you've read the most, or your favorite book of last year, 2022, and why?
Well, we actually have kind of like a little non-official book club at work. And that's kind of what re-inspired my reading hobby, because I was so burnt out on reading from nursing school that it took me several years to get
Happens
back
to
into
everyone. I'm
actually.
telling you, happens to everyone. Yeah, you're like, I'm
Yes.
done reading.
Yes, done for a long time. And it took me a
Yes,
couple years to get back into it. But some of the girls at work will read like on their lunch break. And if I happen to walk back there to go to the bathroom or something, then I'll walk by and I see them and I'm like, oh, what are you reading? And then it just started this whole thing where, one of my best friends, she would be like, oh, I'm reading this book. It's really good. You want to borrow it when I'm done? And so then I would borrow it. And then someone would see me reading it and then they'd want to borrow it.
I love
And so
that.
we've kind of started this little like cascade of book sharing between most of the night shift on my unit, and even some of the day shift nurses will just kind of share books back and forth with each other. But I really liked last year, one of my best friends, she got me into reading this series called A Guitar. I don't know if you've heard it. A Court of Thorns and Roses
Oh,
is
I've
the
seen
name of
this
the
book
first book.
everywhere. I have the
Yes.
first Audible book. Not many, a couple of nurses on my unit have been reading it, and I got the Audible. But
Yeah,
fairies,
I
wizards, is that
I
because I haven't started
know.
it? I haven't started it, so I have no idea.
I'm not a fantasy person at all. It was like pulling teeth for me to watch like Lord of the Rings or anything like that. I'm not big into fantasy at all, but she was like, this is so good and it's not even like that crazy wild. You're going to love it. And so I started reading that last year, and then like three other girls all read it, in sequence, and it was really good. So that was probably my favorite book last year.
It
And I
has to be
finished
because
the series.
oh, congrats! Yeah, because I was about to say in your story of your books, I saw the second or the third. And anyways, yes, of course, it has to
Yes.
be. It has to be. So
Yeah,
you
I
do
finished them.
recommend? You do recommend it?
Yeah, it was really good. It really grips you, and I will say, like, even if you think you're gonna quit or if part of it is like a little slow, once you get to the last 100 pages of every single one of her books, pretty much except the blue one, you could probably just skip the blue one, which I think is the third.
Five and don't play.
But every single one of them, once you get to the last 100 pages, it like everything happens so fast, and there's always a twist or a turn or something that comes at you at the very end. And so I would text my friends that had read it on the unit, and I'd be like, what, this happened? And they'd be like, yeah, I told you. Yeah, I was hoping you'd get to that point. I wanted to see your reaction. And
I
so
love
that was
that.
kind of fun, because it was kind of like a little like unit bonding experience, because every person has read it. Even one of our PRN girls started reading the book, and I'll just see it on her stories every once in a while. I'm like, hey, that's the best one. But yeah, we all joked about it. We were like, the blue one, that's the Christmas special. Don't
Of
even bother with
course.
it. Just skip past that one. But all the other ones are really good. So those were good. But I think, I don't know that I've actually bought anyone a book in the last several years, but I know I have recommended several books. And I was a big Hunger Games girl when I was
Oh,
in
good for
like
you.
middle school. And they came out with a new Hunger Games book, I think the year before last. And so I read that one, and I've been recommending it to everyone because it was really good. But
Do you recommend
I
it to
I read
folks who
that.
have not read the series, or only if you've read the series?
I
Would it
think
make
you could
any sense?
honestly, I think you could read it without reading the series. I think that it was kind of a prequel.
Oh,
So
I
it was
see.
like
Okay.
before, it was like way before the
Katniss
first
Everdeen
book
did her
takes
thing.
place. Yeah, it
Yeah,
was like 50 years before, something like that, and it was about the President Snow guy. So I
that's
think
lovely.
you could pretty much probably read it without that. If you have the general concept of what the Hunger Games is, then you should be okay to go
And if you've seen
and
the
reading that
movies,
one.
it should make sense.
Oh yeah, yeah, yeah. If you've seen
Okay.
the movies, it would definitely make sense. But and I hear that they're actually making a movie out of it
Of course
soon,
there.
so hopefully that'll be good.
Piper, you've been fantastic. Thank you so much for spending all this time with me. Before we go, obviously, number one, anything that we haven't touched, anything that we haven't mentioned that you would like to talk about, share, explain?
Um, I nothing that I can think of right now.
Wonderful.
Yeah.
Yeah, I did really talk your ear off, so thank you.
Oh,
and,
that's okay.
and then lastly, please tell the folks at home. It's going to be in the description box down below. But please tell the folks at home, where can they find you? Tell them your socials.
Oh yeah. They can find you can find me on TikTok at Nurse Pips or Instagram, same handle at Nurse Pips. I post pretty regularly on my Instagram, not quite as regular on my TikTok, but I try to pick up on it every once in a while. So it's just kind of a fun little hobby for me. So I'd love, if people interact with me on there, that's how I love to bond with people
I
over
do have to say, for
DMs and
those out there,
messages.
yeah, that's how I reached out. So she's not lying. I wouldn't tell you if she were, if that, but I reached out via Instagram. I reached out via TikTok, and she responded. She got back to me. And for all you nurses out there, it's not your social. The reason I reached out is because you look like you're having such a good time in life. Like, you seem like such a happy human being, and you're a NICU nurse, which is a very stressful job. So I was like, she must be doing something right. She must enjoy her job. And that's why I reached out. You guys, if you do follow her, it's a really nice break to see a nurse be so happy and live that life. So Piper, thank you so much. Uh, keep in touch,
No
but we'll talk when we
problem.
talk. I
Oh
really appreciate it.
yeah. And congratulations on your baby.
Oh, thank you. 5
What's your
months.
baby's name?
His name is little Leonidas.
Oh, that's so cute. Whenever we have a Leo in my unit, we always make them like a lion footprint.
Hey, I would love that. I'd love that. I'm gonna tell the girlfriend we gotta make some lion footprints over here. Um,
Yeah,
I'll
yeah.
I'll send you some pics on the Instagram. He's adorable. He's
Yes,
absolutely
please.
adorable.
Yeah. Or you can make a if you give me a picture of his footprint, maybe I can paint one for you. Make him a lion. I can
You're
mail
too
it to
much.
you.
You're amazing. You're amazing. I
Five
might take you up
months.
on that offer, but you're
Heck
amazing.
yeah.
Um,
Yeah. That'd be
Piper,
fun.
have a good night. Make sure that I know I'm so sorry about your husband. I hope everything with him is okay. But have a good night.
Yes.
Thank you so much.
I will say that was an eye-opening experience. So it's very different being a patient family member than being the nurse that day.
I
But
bet it is.
it
I
all
bet it
worked
is.
out. So yeah, we're all good now. He's upstairs healing. So I'm gonna go see if he wants some dessert or something.
You're a good lady. Have a good night.
All right, you too.
Bye bye.